Hi, everyone. We're just going to give it a couple more seconds to let everyone get in. Hello, everyone, and welcome to the third webinar of the APDA Connecticut Chapter Educational Webinar Series. My name is Marlene Argianis. I am the chapter coordinator for the American Parkinson Disease Association Connecticut Chapter. Thank you so much for joining us today. We are extremely grateful to Dr. Veronica Santini for volunteering her time to present today's topic, Autonomic Dysfunction in Parkinson's disease. After some brief announcements, Dr. Santini will give her presentation, and then we'll be answering your questions in the Q&A session. American Parkinson Disease Association Connecticut Chapter, or APDA Connecticut for short, is part of the largest grassroots network dedicated to fighting Parkinson's disease and works tirelessly to assist more than 1 million people with Parkinson's disease in the United States live life to the fullest. In the state of Connecticut, there are approximately 10,000 people living with Parkinson's. The APDA Connecticut chapter offers a variety of services in the state of Connecticut. Please visit our website to explore all that we have to offer. Our website also hosts a vast array of publications, webinars, articles, and information that can help you understand Parkinson's disease. If you are participating from another state, we have chapters and locations throughout the United States. And you can find that contact information on our website as well. APDA Connecticut is available through our helpline, email, as well as via our social media outlets. A special thank you to our educational webinar series sponsors, our silver level sponsor, Synovian, and our bronze level sponsor, Abby. Please visit their websites for more information about their products and services. A question and answer session will take place immediately following Dr. Santini's presentation. You can type in a question at any time during the presentation, and we will answer as many questions as time allows. And now to begin our presentation, we are delighted to welcome Dr. Veronica Santini. Dr. Santini is an associate professor of neurology at Yale School of Medicine, where she is particularly specialized in the most complex movement disorders patients. She was recruited to Yale as a clinical chief of the Movement Disorders Division and inaugural director of the Comprehensive Parkinson's Disease Care Program, where she hopes to transform the care of movement disorders patients. Dr. Santini also provides neurologic care to the impoverished nation of Haiti since 2013 and had devoted her time as a medical educator locally and nationally, focusing on increasing student understanding of neurologic disease and increasing the medical student pipeline into neurology. Dr. Santini was selected as a 2016 Academy of Neurology Emerging Leader, and also a 2015 AAN Panatucci Advocate, and has won numerous teaching awards. We're so excited to have Dr. Santini here with us today. Dr. Santini, welcome, and thank you so much for joining us.
Well, thank you so much, Marlene, for that lovely introduction. And I'm excited to talk about autonomic dysfunction in Parkinson's disease, and specifically the important issue of orthostatic hypotension. Our roadmap today will define what autonomic dysfunction is, We will recognize the multitude of symptoms that can arise due to autonomic dysfunction and some features of our evaluation process. And I hope to elucidate some of the therapies that can be helpful. Because this is such a big topic, I'm going to touch on the features of autonomic dysfunction. But when discussing treatment, I'll mainly focus on the treatments of orthostatic hypotension. The autonomic nervous system controls automatic functions of our bodies. Things that just work automatically that we typically don't have to think about. It brings function to gut muscle, heart muscle, glands like sweat and saliva glands. And it regulates these automatic functions such as heart rate and blood pressure, digestion, urination, sexual function, temperature regulation, and sleep-wake cycle. Parkinson's disease and its two sister disorders, dementia with Lewy body and multiple system atrophy, have dysfunction of the autonomic nervous system. When we think about the autonomic nervous system, we think about two big parts, the central autonomic network and the peripheral autonomic network. In this figure, you can see the many parts of the brain that compose the central autonomic network. Areas like the insula, the prefrontal cortex, the amygdala are all involved in higher autonomic autonomic control related to emotions, memory, and stress. Areas in the more primitive part of the brain, we call that the brainstem, are concerned with taking inputs from our organs, inputs from our fluids, and from outside sensory stimuli, and making changes to the heart, blood vessels, and the breathing systems. And importantly, this central autonomic nervous system, the central system, automatically varies with things like behaviors, circumstances, and sleep-wake cycle. The peripheral autonomic nervous system actually comes down through the spinal cord and sends signals all throughout the body. I want you to look at how many body areas are affected by the autonomic nervous system. Our eyes, our gut, our bladders, our lungs, our hearts. This peripheral autonomic nervous system is made up of two divisions. The sympathetic division gives us the so-called fight or flight response. It's activated during exercise, during excitement, and during emergencies. And it has the ability to activate many things all at once. The peripheral division, the parasympathetic division, it allows the body to do functions that are associated with resting and digesting. And it's really concerned with conserving energy. It gives very localized functions throughout the body. So how does the sympathetic and the parasympathetic divisions do what they're supposed to do? It's really based on their structure. And so let's look at the structure of each one of these. Now remember, the sympathetic pathway is the division that helps us quickly react. It's fight or flight. And it's able to do that by getting signals from the spinal cord, meeting up with a connecting cell here, and then it sends out many, many branches to activate many organs all at once. It activates body regions with the use of a chemical called norepinephrine. The parasympathetic division, it takes a little bit more focused approach. It sends fibers a long distance, much further away from the spinal cord, and connects with the connecting cell that's closer to a very localized body region to have a very localized effect. The sympathetic nervous system, the sympathetic system uses acetylcholine as its main chemical, but you can also see that acetylcholine is also playing a role in both systems. I bring up these chemicals not because you need to memorize them, but because they might become important when we talk about the medication treatment options later on. So, How does our body respond to a change in gravity? That is what happens. We stand up and gravity pulls down on our body. When we stand, up to a liter of blood pools down in our legs and into our pelvis. And that means that there's a decrease in the amount of blood returning back to the heart. There's a decrease in the amount of blood pumping out of the heart, and therefore blood pressure drops. When our automatic functions are behaving normally, there are sensors in the blood vessels in our neck and in our heart and in our chest that sense this decrease in blood pressure, and they activate the sympathetic nervous system. The sympathetic nervous system then sends signals to the blood vessels in the legs and the arms and tells them to tighten. Blood pressure increases and heart rate increases. And it's with this reflex that allows us to maintain our blood pressure every time we stand up from seated position. Patients with Parkinson's disease and dementia with Lewy body have problems with the peripheral autonomic nervous system, though. And these sympathetic and parasympathetic divisions, and specifically the connecting cells I told you about, are not working so well. The cells have less fibers actually going to the organs that they're supposed to be affecting. The cells also make less of the chemicals that affect the organs. And the system then doesn't work automatically as it should. Without these fibers and those chemicals, blood pools in the legs and in the pelvis, and the heart and the pumping of the heart doesn't increase. And in fact, it's this blunted heart rate response that's the hallmark feature of orthostatic hypotension in Parkinson's disease. Okay, so now that we have an understanding of all of the structure a little bit better, let's get to some strict definitions. Orthostatic hypotension. This is a drop in the systolic blood pressure, the upper number on the blood pressure, by greater than 20, and on the lower number of the blood pressure, the diastolic pressure, of greater than 10, within 3 minutes of standing. But a small subset of patients might actually have delayed orthostatic hypotension, in which that drop in blood pressure happens after 3 minutes of standing. So orthostatic hypotension can be caused by many things. How do we know if orthostatic hypotension is caused by Parkinson's disease, since it can be caused by so many things? Well, in neurogenic orthostatic hypotension, the kind that we see in Parkinson's disease, we tend to see a blunted heart rate response, despite the blood pressure dropping. So we look at the change in heart rate and compare that over the change in blood pressure, the top number of the blood pressure, and it turns out that ratio is pretty reliable to measure in the clinic to identify neurogenic orthostatic hypotension. And then there's such thing as severe orthostatic hypotension. And that's a drop in the top number of the blood pressure by greater than 30 points, or in the bottom number greater than 15 points within 3 minutes of standing. We do see severe orthostatic hypotension in Parkinson's disease. And it's very definitely seen in multiple system atrophy, where about 70% of patients complain of this or have this in their condition. And there's one more definition worth reviewing, and that's supine hypertension. Supine hypertension is defined as high blood pressure when lying flat, and it can affect approximately 50% of patients with neurogenic orthostatic hypotension. Supine hypertension can worsen orthostatic hypotension as well. And we know that this can also increase the amount of water we get rid of overnight, making us more dehydrated and making patients urinate more frequently overnight. So what happens is that people have very low blood pressures during the day and can't function, and then at night their blood pressure goes very high. So what are the signs and symptoms of autonomic dysfunction? Well, first, let's talk about how we evaluate someone with autonomic dysfunction. we've got to be able to take a history of autonomic symptoms and recognize those symptoms. We also want to review their medical problems and their medication list. We're going to do an examination, and you'll see some examples of things we're looking for on examination. We'll check orthostatic blood pressure and heart rate, and sometimes we monitor even at home these orthostatic blood pressures. If necessary, we might do autonomic testing or specific cardiac scans, heart scans, and other medical tests, but it's not always necessary. So signs and symptoms. I think many people on this call might be able to relate with some of these signs and symptoms. Autonomic dysfunction affects the gut, and including a slow gut, a slowly moving gut. So people eat a little bit of food and they feel very full early. They might also have a reduced appetite, and rarely they might have pain. I think many people, anybody who's ever suffered from constipation might be able to relate to this graphic, as it can really wreak havoc on our system. Vision can be affected, as well as our pupils and their ability to change in low and bright light settings. So people will describe blurred vision or poor night vision. People may have dry eyes. And you can see here that in a bright light, a pupil should be nice and small, but in this person who has only problems on one side of their face, the pupil didn't really react the way that it should. The converse can happen at nighttime when we want our pupils to be big, but they remain small. It will affect our vision. There can be skin changes and decreased sweating and flushing. Some of the skin changes you can see is, there can be a bluing of the skin, or also we can see that the skin can get very red sometimes. Also, if you were to touch this foot, this is a normal foot in comparison, but if you were to touch this foot, it might feel very cold. So the temperature regulation is off. Sometimes in autonomic dysfunction, we can see a mottled appearance of the skin. Be aware that this is also a non-dangerous side effect of one of the medications we give regularly called amantadine. But in this circumstance, it's a sign of autonomic dysfunction when the patient's not on amantadine. We can see also that people with Parkinson's disease might have decreased sweating or flushing. So they're not able to kind of release and regulate their temperature as we would normally expect. People may have dry mouth, but more often they have drooling or excessive saliva and runny nose, sometimes tearing of the eyes as well. And then bladder dysfunction and sexual dysfunction are very common. I wanted to spend a little bit of more time talking specifically about orthostatic hypotension and its symptoms. So typical symptoms of orthostatic hypotension that you might typically get asked about include things like lightheadedness and dizziness, almost passing out or passing out, some visual blurring or tunnel vision, generalized weakness and fatigue, and headache is a common symptom. But less commonly, these symptoms are the ones we're trying to also identify. So many times patients will, and we think a lot of these symptoms are due to a decrease in the blood supply to either parts of the brain or parts of the body. So patients will describe their legs buckling under them, walking difficulties, imbalance, and falls. And a lot of this might be due to the blood flow not getting to the very front parts of the brain that are controlling our legs. People often describe confusion or a decline in their thinking. Again, that blood supply is just not quite getting to those highest level brain centers. Shortness of breath often happens in orthostatic hypotension because these top lung portions are not getting the blood supply that they need. Chest pain can happen if you're not getting blood to those heart muscles. Sometimes people describe coarse jerking movements. And often there is a description of a neck pain, or what we call a coat hanger headache. It's given that name because if you think about where a coat hanger is when you hang up a jacket, sort of in this area, we think that's due to not getting enough blood supply to the muscles all the way up here in the neck. And then very often I hear that patients have excessive daytime sleepiness. They're sleeping all day long. Very rarely, we might see focal deficits, like somebody looking like they had a stroke temporarily, or we might see dystonia, some abnormal cramping of the arms or the legs. If you had to ask me, the symptom that I hear most often when it comes to orthostatic hypotension, it's definitely legs buckling, walking difficulties, and falls. So I'm very attuned to this and the possibility that orthostatic hypotension could be a cause. But then, why are we seeing so many patients that are having symptoms in that middle column or the last column? Why don't they have all the typical symptoms that we think about when we think about orthostatic hypotension, like lightheadedness? I never hear my patients complain of that. They say, but doc, I'm not lightheaded. And the reason is that your brain is sort of auto-regulating how much blood flow it's getting. And it gets used to having really, really low blood flows. So even though it's normally right about here, it gets used to the blood pressures down here. And so patients say, but I don't have any symptoms, but their function is being affected. And it should be an indication to treat. What else should we be looking for? Well, why don't we go ahead and check and make sure that we actually have orthostatic hypotension at play by checking orthostatic vitals with the blood pressure and the heart rate. We do this by having the patient lie flat for 3 minutes, check their blood pressure and their heart rate, and then they stand up, wait 3 minutes, and check their blood pressure and their heart rate. Does it meet criteria for orthostatic hypotension when we do that? Does it meet criteria for neurogenic orthostatic hypotension? We also want to rule out other non-neurogenic causes, like dehydration is a common cause of orthostatic hypotension. Physical deconditioning. In fact, the first people in the 1930s that Dr. Yohimbe ever discovered to have orthostatic hypotension were people who had been in the hospital for a prolonged stay, and they had been kind of recumbent for a long period of time. Just like our muscles can get deconditioned if we're not physically active, the same thing happens with our autonomic nervous system. People who have heart failure, anemia, they may also develop arrhythmias. They may also develop orthostatic hypotension for different reasons. And then you want to do a good comprehensive review of the medications they're on, and additional testing really only if needed. I often will do it if there's MSA that's suspected and I'm confused by the clinical picture or something like that. So what does autonomic dysfunction in Parkinson's disease look like? Well, first off, you should know the symptoms are super common. 65% of people with Parkinson's disease have constipation, 34% have urinary symptoms, and 30 to 65% will have documented orthostatic hypotension. And some of these symptoms can precede the onset of motor symptoms by many years. For instance, many patients that I'm first diagnosing with Parkinson's disease will say, I've had constipation for years or almost lifelong. Many become more frequent as the disease progresses, like neurogenic orthostatic hypotension. But we know that these autonomic dysfunction symptoms are present and common even in early disease. So when asking patients to report their symptoms, one study specifically looked at autonomic symptoms over time and found that 71% had at least one symptom at diagnosis and 100% had symptoms by 3 years. Of the over thousands of patients that were Parkinson's patients who were part of the Priamo study, 15% of them had passed out or were lightheaded when standing. And 10% of them had never taken medication, which begs the question, is this the medicine or the disease itself? And when we do testing on patients in early stage disease who are on no medications whatsoever, we find that a third of them have documented orthostatic hypotension and impairments in their deep breathing, and their heart rate does not respond to different situations as it should. So this is an issue of Parkinson's disease. But what is the contribution of medical therapy? Well, there is some contribution. So carbidopa-levodopa, the best drug that we have for Parkinson's disease and the one we use most often that will relieve your motor symptoms, it doesn't really worsen the postural change, so the change from seated to standing or laying down to standing, but it overall lowers blood pressure. So it lowers the baseline blood pressure by about 20 points. And it also may decrease blood pressure boosting chemicals. It may increase the pooling of blood in the legs and the pelvis. And it might also have a diuretic effect. And it may also lower the heart rate. So it does all of these things to the cardiovascular system. And we know that MAO-B inhibitors, amantadine, dopamine agonists, all mainstays of treatment in Parkinson's disease, small studies have shown that it may actually worsen orthostatic hypotension. And then when you think about combination therapy, which we do with most patients, that might also increase dysfunction. So there was a recent big meta-analysis that looked at all the studies that reported orthostatic hypotension as a result in their drug studies. And there were really contradictory results. They found that they weren't able to really pinpoint any medicines having any effect on orthostatic hypotension. But everybody who treats patients with these conditions would have a different story to tell. They would say that's contradictory to what we know clinically. And the authors in this article actually acknowledge that. And they say probably the articles the studies done did not report this as an abnormal finding or an adverse event. So we don't have great data on what these drugs are doing, but overall they likely lower blood pressure in this, and in particular in the setting of orthostatic hypotension. So what's the impact? The impact is significant. Studies have shown that it worsens quality of life, that orthostatic hypotension worsens cognitive dysfunction, and it worsens thinking immediately. If you lay people down, actually, sometimes they do better on neuropsychological tests. But it also gives a higher risk of long-term cognitive decline. And that risk is even higher if they have both orthostatic hypotension during the day and supine hypertension at night. It increases falls, and studies have shown that motor symptoms are worse when somebody has low blood pressure. And it worsens prognosis. But the good news is that early screening and treatment can actually positively impact the entire disease course. So why am I excited to talk to you guys today? Well, in this study, even though patients very regularly had autonomic dysfunction, this study showed that only 40 to 50% of them were talking about these symptoms to their healthcare providers. And so I hope that by educating you today, you'll be able to recognize the symptoms that could be related to autonomic dysfunction, and that you'll discuss these with your healthcare provider so that you attack it with the right therapy. So let's go ahead and talk about treating orthostatic hypotension. This is probably the most important. And it's going to take a lot of hard work. So my approach to the treatment of orthostatic hypotension is this. You really got to understand the symptoms the patients are having. You have to understand their medication list and other diagnoses they may be dealing with. There's a whole slew of conservative therapies that patients have to partake in. And doing the conservative therapies will help, but they're not always enough. And in which case we have to start medications. We've got to adjust those doses, and we've got to use combination therapies very often, meaning multiple medications. And all of those in conjunction with the conservative therapies. I have a few very basic goals. I like to stop people from passing out or almost passing out. Then I like to stop those lesser known symptoms of orthostatic hypotension. And although I'm not treating a patient based on numbers, I do have goals with the blood pressure. I know that if your standing blood pressure is above 100/70, you're probably doing okay. And we can just keep working on conservative therapies. But if it's below 100, we will be having problems. And we want to balance blood pressure medications and medications for Parkinson's disease, because we don't want to hold back on giving people medications for Parkinson's disease when they need them. If it just means we have to boost the blood pressure a little bit more, no big deal. So, reviewing other diagnoses, which ones are important for us to know about? Heart failure, previous stroke or heart attack, kidney failure, and I forgot to put on there arrhythmia. Why are these important? Well, they may alter what medications we can use, and they may alter our thought process of this if this is only due to orthostatic hypotension versus neurogenic orthostatic hypotension. We also want to review the medication list. Why? Because many people are still on antihypertensive medications, anti-high blood pressure medications, and we can simply take those away and people will feel much better. Urinary medications are often the cause of low blood pressure. Now, we may want to balance that with what they need for their urinary needs. And then levodopa, dopamine agonists, the medications we use for Parkinson's disease, we might want to be creative in how we dose them. So for instance, can we give smaller amounts more frequently instead of one tablet every 4 hours of carbidopa, levodopa that you give? Maybe we can give half a tablet every 2 hours. It might prevent some of the peaks and valleys where the peaks are really lowering the blood pressure too much. We might also switch to long-acting agents that might lower the side effect profile, giving a little bit more steady state of the drug. Again, getting rid of some of those peaks and valleys. And we want to avoid certain things in orthostatic hypotension. So let's help ourselves and avoid these things. Number one, please avoid dehydration. I would say that many people are dehydrated, and I would say about 80% of people who cross my path in clinics, whether they have Parkinson's or not, are not drinking enough water. So we'll talk about that. Darkly colored fluids are going to lead to dehydration. Even those teas that are decaffeinated that you like so much, if it's darkly colored, it's most likely dehydrating. Standing motionless is a big no-no when you have orthostatic hypotension. So instead of standing motionless, now you must learn to march in place or go up and down on your tippy toes, or sometimes swaying side to side. I sometimes do some of these maneuvers to see if anyone will think that, it's strange what I'm doing and to keep my own blood pressure up. And I think it just looks like normal behavior. So no more standing motionless. Rising quickly from lying down or seated positions, also a no-no. We want to kind of activate our legs. So we want to do some heel raises. We want to kind of march in place before we stand up. And then once we stand, give ourselves a little second to acclimate, hold on to something. Climbing stairs can be another opportunity where gravity pulls our blood down into our legs and into our pelvis. So we want to take these carefully, not running up the stairs, but also being ready by pumping our leg muscles and things like that. Working with our arms over our head is a lot of stress on our blood pressure system because now it's got to get blood all the way up to where our hands are. So that can be very challenging. Vigorous exercise opens up the blood vessels. Hyperventilation does the same thing. Heat, hot baths, and hot environments, as much as possible, avoid these things because it opens up your blood vessels and then blood pools down in your legs and your pelvis. Large meals. If we want to take in a large meal, then what happens is our blood rushes to our guts so that we're able to digest that meal. But in our case, we need to keep our blood pressure up, so this can be a problem. Alcohol consumption, again, opens up blood vessels. Fever makes it even worse because then you sweat with those open blood vessels and you become dehydrated. Straining with urination or defecation. When you strain really hard or you have coughing spells, our body is told to go into that rest and digest mode and drop the blood pressure. And then rapid ascent in high altitude can be very challenging for patients with Parkinson's disease, and a plan can be made to fight against that a little bit when we know we're going to be doing that. All right, so what is our to-do list for those of you who are action-oriented? Okay, we've got a bunch of things we can avoid, but what can we actually do to feel better? Well, number one, probably the hardest thing for most people is drink lots and lots of water. You should be drinking half your body weight in ounces. So take your body weight in pounds, divide that in half, and that's how many ounces you should be drinking every day, as long as you don't have restrictions for medical reasons. This is really helpful that you keep your volume up every single day, but also when you're feeling bad in the moment. Studies have shown that if you can down half a liter of cold water, you can boost your blood pressure up by quite a bit, and it can relieve a lot of your symptoms. So drinking that much water is not easy. It's not really so much if you like water or you don't like water. This is kind of one of those things you got to do it whether you like it or you don't. I didn't really like drinking water, but now I drink a ton of it. And it's hard for me to keep up with my water intake. So what do? I get a water bottle that I know exactly how much is in there. This water bottle, you can get any one, but I like it very much because I know how much is in there. 20 ounces of fluid is in there. And you can't see in the picture, but it's got a little dial here. So every time I refill it, I can switch it 1, 2, 3 to keep track of how many I've had during the day. And you want to fill this up regularly, have 3 to 4 at least of these 20 ounces per day. Salt tablets are salty foods with every meal. So with every meal, you have something salty. Things that have salt in them are non-low sodium, tomato juice, canned soups, deli meats, pretzels, salted nuts, chips, go crazy, pickles. Anything salty. If you're someone who's like, I really don't like salty foods, then we can prescribe you salt tablets that give you 1 gram at a time that you just pop in and take down your throat. How much is too much salt? Well, in orthostatic hypotension, as long as you don't have any contraindications like heart failure, we typically say somewhere between 5 to 10 grams of salt a day. That's a lot of salt. So you can go pretty heavy on the salt as long as you don't have other medical problems. Multiple small meals during the day. So you heard me say 1 large meal, not good. It sends all the blood to your pelvis. Multiple small meals, very good. Spread them out. It turns out that also helps the slow gut. Elevate the head of the bed. When we lay flat, we urinate more overnight and our body gets used to laying flat. So I recommend people get a wedge pillow and elevate the head of the bed, or if you have an adjustable bed, that's fine too. Elevate the head of the bed to about 30 degrees so that you're not lying flat. Physical maneuvers are able to raise blood pressure. So when you're feeling bad, do some calf raises as you're standing there. Cross your legs and really activate your legs. Squeeze them tight. Put one leg up. You just look like you're very interested in what somebody is saying. These can all be helpful. When temperature regulation is a problem, cooling vests can really help out, or cooling scarves. Leg sleeves. Now, I'm a big fan of compression stockings, but who the heck can get them on their legs? Not many people. So I really like to advocate for leg sleeves. It doesn't matter if you use this brand or another one, but what's good about them is that they go from the ankle to the knee, and they're much easier to get on. They come in many styles and colors. And you can get several pairs, but just make sure that they're tight on your legs. They won't do anything unless they're nice and tight. And then abdominal binders. So if you're somebody who gets low blood pressure after eating, throw on an abdominal binder, wrap it tight around your waist about 10 minutes before you're about to eat, and leave it on for about an hour after eating. That should help with that. And then the most important thing is exercise your legs and your core muscles. You really want to build those up because those are the things that help your autonomic system to recover. So exercise, exercise, exercise. Okay, now moving on to the medications. There's an FDA-approved medication for orthostatic hypotension. It's called fludrocortisone. It sometimes goes by the brand name of Florinef. This is a drug that expands the amount of blood in your blood vessels, and it works with the water and salt you ingest. So if you're not drinking water and you're not eating salt, it doesn't work as well. You can't just take a pill. Like I said, you have to do the conservative measures as well. You can use doses from 0.1 to 0.5 a day, but I typically use 0.1 to 0.2. Above that, I don't find much more therapeutic benefit, but we do sometimes see an increase in side effects. But this is really important. It can cause supine hypertension, and it lasts a really long time in the system. So take that medication in the earlier part of the day, specifically in the morning. While you're on this drug, you need to monitor potassium, magnesium levels, because those can go low on this medication. You would never take this medicine if you have heart failure unless your cardiologist says it's okay. So the neurologist should be talking with the cardiologist. And it does have some side effects like headache, swelling, and waking. Swelling usually happens when someone's not taking enough salt in, because salt keeps your fluid in your blood vessels and not in your feet or your tissues. Now, there's 2 FDA approved medications specifically for neurogenic orthostatic hypotension, and that's Midodrum and the next medicine, which we'll talk about. This is a medicine that constricts your blood vessels. So it kind of boosts the blood pressure by constricting blood vessels, and you can dose it 5 milligrams 3 times a day, all the way up to 20 milligrams 3 times a day is what I do for some of my patients. And it can cause supine hypertension, like we talked about with the last drug. And therefore, you want to give the last dose in the late afternoon or early evening. Side effects are kind of funny with these drugs, so with this drug in particular. So the side effects show actually make sometimes people have dilated pupils, so their vision can be a little bit blurry. People will complain of goosebumps and often have pins and needle sensations, a lot of times in their scalp. Sometimes we also hear itchiness with this medication. So likely a side effect, not harmful, but kind of funny side effects for sure. And then I just wanted to remind you all the way back from the beginning of the talk about those chemicals we talked about. So remember that the chemicals are the norepinephrine and this acetylcholine. This is coming into play because now we're going to talk about medications that specifically affect those. So the other FDA approved medication for neurogenic orthostatic hypotension is DroxyDopa. And this medication is a newer medicine. It's a norepinephrine prodrug, meaning as soon as you ingest it, it becomes norepinephrine, and it also constricts blood vessels. You can use a small dose or you can use up to 600 milligrams 3 times a day. And it works very effectively, no matter what. But it's best when people know that they have low supine plasma norepinephrine levels. We can see this sometimes when we do autonomic testing, but not a necessity to take this drug. It can also cause supine hypertension, and headaches, dizziness, and nausea can be side effects with this medication. Now, one of the non-FDA approved medications is Parotostigmine, and that works on that other chemical, acetylcholine. It makes more of it available in the system. This is not a heavy-duty drug. This is a drug that does improve the standing blood pressure. So when somebody is standing and their blood pressure usually drops, it bumps it up just a little bit. But again, it's not a heavy-duty medication, which may be inadequate to treat symptoms. It does not worsen supine hypertension, though. Of all the medicines that we talked about so far, this is the only one that doesn't worsen supine hypertension. And it's effective alone or in combination. And it has also some not so pleasant side effects, although in the setting of Parkinson's disease, where most people have constipation, it usually just relieves constipation. So that may be an added benefit side effect. Another non-FDA approved supplement that has been looked at is Yohimbe. And this one also will increase plasma norepinephrine and increase blood pressure. They looked at it in animals. It seemed like, maybe it doesn't drop the blood pressure so much. But when they looked at it in 17 Parkinson's patients in a pretty good level of science study, randomized study, it didn't show any effect. In a study that was less scientifically rigorous, it seemed to show a dramatic effect in blood pressure. But again, it wasn't a scientifically rigorous study. And it also has side effects, including confusion, which is somewhat concerning, but also tremor. Deep brain stimulation. Sometimes when we can lower medications, we might be able to improve fluctuations associated with blood pressure. There was only one study that looked at deep brain stimulation, and it seemed like it could improve the blood pressure and fluctuations, but the jury is still out about the effect. Here's a whole host of other compounds that have been studied. None of them are FDA approved, and they are small studies. I'll just leave this with you all to kind of take a look at what each study has done. You can maybe pause this later if you're reviewing the video. And then I would be amiss to not mention the treatment of supine hypertension. So supine hypertension is where we, again, have the high blood pressure when we're laying flat. So you might say, well, why do I have to treat it? Well, again, it can affect cognition. It can cause end organ damage, risk of stroke, and heart disease. So what we sometimes do to evaluate this is do 24-hour blood pressure monitoring. And the reason to do this is because sometimes when people first lay down, their blood pressure is very high, but over the course of the night in their sleep, the blood pressure may improve. And if that's the case, you don't need to treat it. But what we do for those who really do have supine hypertension is the first thing first. It seems obvious, but don't lay down during the day. If you want to rest, take off your compression stockings when you rest and rest in a more seated position. So if you have a recliner, rest with the head of the bed up. You can also tilt your bed at night by 10 degrees, which might be hard to do. And if that's too challenging, just simply sleep with the head of the bed up. So this helps both the orthostatic hypotension during the day and the supine hypertension at night. Remember, I told you don't eat those large meals with heavy carbohydrates. Well, why don't you have a carbohydrate snack here at bedtime? That can lower the blood pressure. Beware of any hidden boosters of blood pressure. So some things that wouldn't normally increase blood pressure in people with neurogenic orthostatic hypotension, they can have significant increases in blood pressure with things like ibuprofen, indomethacin, and atomoxetine. So those medicines really should not be given at night. And then what we often do is we end up boosting the blood pressure during the day with any of the medications that I mentioned, and then using short-active anti-high blood pressure medicines at night. And those risks and benefits need to be weighed. I typically like to start with fludrocortisone. If people are drinking water and eating salt, then I may add Midodrum and then work on Northera. Usually DroxyDopa, Northera is such a strong medication that I might have to pull away some of the other two. Sometimes we need to use all three and even more, but always we have to do our conservative therapies. So key points: that Parkinson's disease mainly affects the peripheral autonomic nervous system, that symptoms are very prevalent throughout the disease course, even in early disease. They can have a huge impact on function, and treatment really requires that combination of conservative and medications. But if we do that, we can improve function and long-term risks. This is my awesome team of physicians and our physician assistant over at Yale. What's not represented here is the amazing team of nurses and neurorehabilitation specialists and everyone else. So I'll try and get them all on my next slide. And I also just wanted to bring awareness to the first ever World Movement Disorders Day on November 29th. The Movement Disorder Society is putting this on, and you guys can register and be part of that, the excitement of spreading the word about movement disorders. And then I just wanted to thank you very much for your attention. I hope this was beneficial, and ask you for any questions.
Thank you, Dr. Santini, for this very informative presentation. We have several questions that have already been submitted to us to start off today's discussion. But if you are participating live today and you have a question for Dr. Santini, you can ask your question using the Q&A feature on Zoom. We have a special guest to oversee the question and answer segment, Dr. Rebecca Gilbert. Rebecca Gilbert joined APDA in 2018, bringing a wealth of practical experience in diagnosing and treating Parkinson's disease, as well as a strong background in fundamental and clinical science to the team. She is responsible for overseeing APDA's research portfolio in conjunction with APDA's Scientific Advisory Board, and also provides medical and clinical expertise to support APDA programming, as well as print and web content. Dr. Gilbert received her MD degree at Weill Medical College of Cornell University and PhD in cell biology and genetics at Yale Graduate School of Medical Sciences. She then completed her neurology residency, training as well as movement disorders fellowship training at Columbia Presbyterian Medical Center. She continues to maintain a limited schedule of patients 1 day a week through Bellevue Hospital Center. Welcome, Dr. Gilbert.
Hi, everyone. Let's turn on my camera. Okay, hi, how are you doing? Thank you, Dr. Santini. That was an amazing lecture. I learned a ton. We have questions pouring in. So let's get right started. And we have a great question here. Is there one definitive measure to determine if one has orthostatic hypotension? So what would you say to someone who's not sure if they had it? How would they know?
Yeah, so this is so important. We have to actually make sure you have that, right? So the definition is that you want to take the blood pressure lying down, lay there for 3 minutes, and then take a blood pressure and a heart rate. You can do that on your home cuff. Just make sure that it's an accurate cuff and add a heart rate to that. Then stand up, wait 3 minutes, and take your blood pressure again and your heart rate again. If those numbers drop, so if the blood pressure drops by 20 on the top number and 10 by the bottom number or more than that, you likely have orthostatic hypotension. The other thing I do regularly with my patients is if I'm not catching what I think I might catch in the clinic, I ask them to do those values at home over about a 2-week period. And then I would bring that to your neurologist and say, can you look at my laying down and standing blood pressures and tell me if these are normal or not normal, or if I have orthostatic hypotension and if it could be causing my symptoms.
Fantastic. Great, useful advice. We now have another very good question corollary to that. How do I find a doctor who knows about this and is able to treat me?
Yeah, this one's challenging. So what I would say is if you have Parkinson's disease or one of the like disorders, it would be really important that at least every once in a while you're seen by somebody who's classified as a movement disorder specialist. They can be part of your care team. They don't have to be your primary neurologist, but it's good to have a visit with them maybe once a year and discuss these kind of more specific topics with them. There is actually a lot of physicians who are very well versed in this, including primary care physicians, sometimes cardiologists, sometimes even kidney doctors. But I think a movement disorder specialist would be able to address this, which is often very, very common in the disorders that we treat. So I would try finding a doctor like that and bring it up. Make sure you bring it up.
Very good. We have a great question from Janet. Is there a difference in any of what you discussed between regular Parkinson's and someone who might have young onset Parkinson's?
Oh, that's such a great question because there's often so many differences between the two. What I would say is young onset Parkinson's disease in this circumstance tends to be a little more pure in that you might not have a lot of the other medical problems that somebody with regular aging has. You might not have heart disease. You might not have, other kind of arrhythmias or other heart problems. And so the disease itself, the neurogenic orthostatic hypotension or autonomic dysfunction, is not different between young onset Parkinson's disease and regular onset Parkinson's disease, but you may have the advantage in that you don't have kind of other conflicting comorbidities to worry about. But otherwise, there's not a whole lot of difference between the two.
Excellent, thank you. We have another question which came in during registration. Can you discuss changes in heart rhythm? Is that part of this? Is that something that a Parkinson's doctor would know about? And what to do about heart rhythm issues?
Yeah, this is a great question. So this is the circumstance where I would partner very closely with my colleagues in cardiology and do a full workup of the heart. As you heard me say several times within the discussion, the heart rhythm is lower and blunted. The response is blunted from what we would expect in for normal circumstances in Parkinson's disease. So if there was a lot of palpitations or there was a lot of different arrhythmias or changes in heart rhythm, that would be an indication to look a little bit deeper and really have an evaluation with a heart specialist. There are specialized tests that can be done and rhythm monitors that should be used. This may or may not also be an indication to do autonomic testing at a big center.
Fantastic, thank you. We had another question that came in during registration that maybe you could address as well. Shortness of breath. I know it came up, but maybe elaborate a little bit more. Can shortness of breath be part of Parkinson's? If lung issues have already been ruled out, how do you address that?
Absolutely. Well, as Dr. Gilbert knows, we hear this all the time in Parkinson's disease, and patients really do have a lot of reasons to have shortness of breath in Parkinson's disease. One of them is the issue that I talked about with orthostatic hypotension. The apical lung fields are the ones that are all the way up here, and the blood is just not quite pumping to those areas. So people will feel short of breath when they're exerting themselves, or when they're climbing stairs, or when they stand up from seated position. Another reason why people with Parkinson's disease will have shortness of breath is their rib cage and their lung cage is very tight. So the rigidity that can affect the rest of the body, it can remain tight and sometimes doesn't expand as easily as we would hope. And so patients have what's called like a restrictive lung disease due to that. Sometimes medications can help loosen up the body. So if you're somebody who kind of resists taking medicines to loosen up the rest of your muscles, that might be a reason to loosen them up. And other times, deep breathing exercises and things you can do with speech therapists can also help. Another reason why people have problems with shortness of breath might be related to anxiety, which is a common problem in low dopamine states. So it can be often a manifestation of wearing off of your medications, or just be due to Parkinson's disease itself. So, and then finally, let's not forget that shortness of breath can be a big part of other medical diseases. It can be part of heart disease. If you have risk factors for that, it can be part of lung disease. Maybe there was some smoking in the past, right? So there's lots of reasons why people can also medically develop shortness of breath, even in the absence of Parkinson's disease.
Fantastic. I find that that's an issue that so many people complain about, but we don't address enough. So thank you for that.
Yes.
We have another question, which we touched on, and maybe discuss it a little more. Severe constipation. Somebody has tried everything, has out of options. What do you suggest?
So I'll tell you something. I actually, because it's such a common problem and everyone says, oh, I've tried everything, I have a whole one-page document of tips on how to treat constipation. And I pretty much give it to almost every single patient because it's such a common problem and it's so vexing. So what I would say is, just like with orthostatic hypotension, it's never one thing that's going to fix it. It is a whole host of behavioral things that have to be done, plus medications, and usually multiple medications, not just one, right? We've got to hit that gut from different pathways. So what I would say, that some of the most important tips, I'm going to just harp on this like crazy, is hydration. None of my patients are drinking enough water. Let's be honest about that. And if you increase your hydration, it will help. Things like prunes and dietary changes make a big difference. Going to the bathroom, regulating your gut, starting to train it, going to the bathroom at the same day every time, or at least trying to go. And usually if you can do that after a hot meal, fantastic. But then you got to add your sennas, your docusates, your smooth move teas, and you got to use your Miralax, and you got to use those every single day. It can't be, I use it when I'm constipated and then I don't use it. It's an everyday sort of regimen. And then there's a whole host of medications that can be used by prescription with our GI specialist. And again, it's usually a combination of all of those things. I'm sorry, I know it stinks. I can imagine taking all of that doesn't feel good, but that's how you tackle it.
Fantastic. So it really is a very active process, which is
unfortunately, yes.
very, very, very good information. We are really at the end of the hour with 2 minutes left until 2 o'clock. So let's end with a nice summary question from Shireen, which is, can you have orthostatic hypotension and not know it?
100%. In fact, I spend so much of my time trying to convince people that their symptoms are likely due to the orthostatic hypotension, which I've measured, and that we have to do something about it. Because most of the time patients will say to me, but I don't feel that. And it's mainly because we haven't identified the symptoms that are affecting you. You're not going to have it if none of your blood pressure readings show orthostatic hypotension. So if you've done a log for 2 weeks and never once your blood pressure was dropping, then you don't have this condition and you don't need to worry about it. But if you have weird, vague symptoms and you have a blood pressure log showing that, I think it should be considered in your treatment plan.
Fantastic. Thank you so much for those fantastic answers. I'm going to pass it back to Marlene. Thank you.
Thank you.
Thank you, Dr. Gilbert, for your help. That was wonderful. Dr. Santini, is there anything else you would like to add before we conclude the question and answer session?
I would just say it's a lot of hard work. So please try and work on it. It's just one additional thing we got to add into our healthy living lifestyle: exercise, water, conservative therapies, and don't resist medication management that can help you.
Thank you very much, Dr. Santini. For additional information, answers to your questions, and resources, please visit our website. You can also email or call us via the email and phone number on the screen. Please join us for the APDA Northern Connecticut Optimism Walk, taking place on Saturday, May 6th at the Farmington Polo Club in Farmington, Connecticut. Pre-event activities and check-in are at 10 a.m. Registration will be up on our website soon. Share your insights survey. Please go online and complete our survey. Completing our survey helps us know how to better assist our members and what programming is most important for us to offer. On behalf of the entire APDA Connecticut chapter, many thanks to Dr. Veronica Santini, Dr. Rebecca Gilbert, our participants and sponsors, Synovian and Abby, for supporting our program. If you know someone who missed today's program, if you joined late, or you would simply like to watch again, you can view a recording on our website at apdaparkinson.org/CT within the next day or two. Everybody, happy Thanksgiving and have a wonderful afternoon. Bye-bye.